On behalf of the College of General Practitioners of Sri Lanka, I would like to invite all the young and upcoming GPs to enroll in the MCGP Postgraduate Diploma course offered by the College of GP Sri Lanka. Further details could be obtained from our website. And now we've come to the next segment of our sessions, that is ophthalmology for the primary care doctor. And to chair this session, I would like to invite Dr. Dinesha Anihettiarachchi and Dr. Bihan De Silva. Over to you.
As for the last session of this 46th annual academic sessions held by College of General Practitioners of Sri Lanka, I would like to invite Dr. Amila De Alwis to conduct his presentation on childhood eye disorders for general practitioners. If I may introduce a little bit more about Dr. Amila De Alwis. Dr. Amila De Alwis is MD Ophthalmology, FRCS. Dr. De Alwis is a consultant ophthalmologist practicing in Colombo, having completed his ophthalmology training in Colombo, Singapore, and in the UK. He went to do a pediatric ophthalmology fellowship at the Sick Kids Hospital in Toronto, Canada in 2009. He has been practicing in Colombo since, with interest in pediatric ophthalmology, squint management, and cataract surgery. So it's a podium, and the presentation is all over to you, Dr. Alwis.
Thank you very much, the President of the College and the committee and Madam Chairperson and Chairperson for having me here today. So I was told that I've got to get all of pediatric ophthalmology out to the audience in 20 minutes. So I'll try my best to keep it as simple as possible. So the aims of this presentation is to actually let know what is important in pediatric ophthalmology, what is urgent in pediatric ophthalmology, when to refer patients, and what advice to give parents. So these are the 4 areas that I'm going to actually focus on. Now, I've given this talk a few times to the College of GPs in the past, a few times, and I keep updating these pictures, right? So these pictures show us 5 famous personalities. We know pretty much everyone here. Some of you all had difficulty in picking out the middle personality, who is Hippocrates. So my question, when I put this out to the audience, when your audience was live earlier, was what was common between all 5 of these personalities? So a lot of answers came even the last time I brought this up. And in the sake of, with relations to the talk today, I presume all of them had good vision as children, and that enabled them to achieve what they did in their spheres, in their walks of life. Again, questionable, but I'm assuming this. So the importance of good vision in a child is immense, and we have to realize that 80% of all learning, all input, all what we are, comes through our eyes and the vision that the eyes deliver. So if children don't have good vision and their vision doesn't develop, it's not just that individual child, but the child's family, the next 70 years of that child's life. Then, of course, this trickles down into the country and the economy as well, because then the country is going to be looking after the child and the child not contributing to the country. So the low vision in the child is a very, very significant problem we've got to address. So when you talk about eye conditions, you've got the ones in red now, the refractive errors, very common, squints, cataracts, glaucoma, retinopathy of prematurity, not as common. Then you've got things that are sometimes emergencies, things like injuries and chemical burns. Again, very common things like naso-lacrimal duct obstructions and infections. Retinoblastoma is a malignant tumor in the retina of young children. That is one of the few things that can actually take a life of a child, so I've put that into the presentation as well. Like I said, it's all about what's important, when to refer, and what to tell our parents. So I've played this game as well, just to sort of drive home the fact of what pediatric ophthalmology is all about, right? So when we use, we've done this before as well, I couldn't change it this time around, I just stuck to Kuma. So when we say the word Kuma, the next thing that comes into a Sri Lankan's mind is Sangakkara. For some reason there are millions, maybe hundreds of thousands of Kumas, but Sangakkara is what comes in. So with pediatric ophthalmology, the word, when you hear the word pediatric ophthalmology, the word I would like you to think of is amblyopia, because that's actually the crux of a lot of cases of pediatric ophthalmology, and that's what differentiates pediatric from the less exciting and the less challenging adult ophthalmology, right? But the more lucrative, of course, right? So pediatric ophthalmology, if you just remember from this talk, if you take home, the only word that you got to remember is amblyopia, or the ability for this child to develop a lazy, non-seeing eye, if not, this condition is picked up early and treated appropriately. So amblyopia, we all know, it's just basically a lazy eye. It's poor vision in an eye that is otherwise physically normal. So you have an eye that looks good, but because of some reason the eye is not received clear enough vision, and this has caused amblyopia in the eye. So this is commonly caused by things like refractive errors, strabismus, and cataracts. So when you look at this list, you realize how easy it is to treat these conditions. So really a child developing amblyopia because of not being detected and corrected, I mean, it's close to a criminal offense on our part. So to pick up these amblyogenic factors or these amblyogenic conditions, most associations of ophthalmology, they recommend a quick examination of the red reflexes at birth, then at 6 months, 3 years, 5 years, and every 2 years thereafter. If there is a pathology that we are dealing with, of course, it will be more, it will be at short intervals then. So important thing is pediatric ophthalmology, the potential to develop amblyopia in a child, and we have regular eye checks in children. Now, the problem is that if we let things be and the child's old enough to come and tell us that there's something wrong in one or both eyes, then generally the idea is that we are too late because they've got to be in their teens at least to understand this, and by that time we really cannot correct most or at least the large number of these amblyogenic factors. Refractive errors, it's a very simple, straightforward thing. I mean, I've seen, looking in the audience here too, there's enough of us wearing glasses to know that it's common enough, and it's a problem for us adults, but and we know when there's something wrong. I mean, at 40, everyone who finds difficulty in reading would go and get help, and delaying that won't really cause much of a problem. But in a child who is not aware of what vision should be, they will often delay their complaints, and this will cause a big problem. Now, of these refractive errors, we've got myopia, or being short-sighted, where you can see near but not far. Then you've got hyperopia, and then you've got also astigmatism. But what I would really like to focus on is myopia, or being short-sighted. Now, this is next to corona, I would say, would be the next pandemic to hit us globally, right? So the WHO incidence as of 2016 was 23%. By now, it's up to about 30%. And the predictions are, if we go in the same way, you know, by 2050, 50% of the world's population will be myopic, right? So meaning, in a few years after that, it'll actually be abnormal for you to be able to see clearly, because the majority of the people on Earth would be needing glasses for distance vision. And remember, these predictions were made before corona came into being. And now with corona, we know that all kids have switched to online classes, and the regular talk or the regular advice I would give parents before corona, I'm still giving the same advice, is go outside, get enough sunlight into your eyes, take breaks and reduce screens. So what's happened over the last year is entirely opposite to that. So it's stay indoors, stare at a screen all day, and don't go outside at all because you can't. So what I'm seeing now in my practice is the result of this is in the last few months, I'm picking up these kids who actually progressed, their myopia has progressed much faster than they should, right? So the big problem with myopia is just, okay, you may think putting on a pair of glasses, everything looks good. By the time you're 20, you can do laser correction, and then you'll be okay again. But the problem is, if we've got, let's say, 5 billion myopes by the time we hit 2050, the big problem is that the low-end myopes, the -1s, the -2s, the -3s, oh, that's fine. But the problem is you're going to have such a big number of high myopic adults, right? So -5, -10 and above. So with high myopia comes other big problems like, retinal detachments, cataracts, squints, glaucoma, which will take a lot of effort to treat and manage. So the advice here is, whenever parents do ask about the eyes, is from your part, if you want to prevent the onset of myopia or slow progression, would be to spend adequate time outdoors and reduce screens and take breaks. So what I would tell my parents of kids even now is, you can't use Corona as excuse, because what you can do is, with the online classes, take a break, look at something far away, rest your eyes in between. At the same time, reduce your unwanted screen. So what happens is, what we see now is, during the morning time, they're online. Afternoon, they're offline doing other screen work. So the whole day they spend on a screen. So you can't reduce screen times. And I've had the problem where, I've told them 2 hours of screen, so they've gone and quoted this, saying, my doctor said, even if it's 6 hours, I can only listen to 2 hours. I've got in trouble as well. But what I now suggest is that the online screen time stays the same, but they take breaks in between. They compensate by reducing the other screens and at least spend half an hour to an hour outdoors every day. Garden, balcony, lane, go for a walk, do something until we get back to normal. Because schools were supposed to open 6 months ago. They're supposed to open next month. We don't know how long that will take. Even if schools open, extracurricular activities will take that much longer to get back to normal. So we've got to protect our children against myopia. So that's going to be the next pandemic. So good to know, if not for our patients, but at least our own children, look after your eyes by spending more time outdoors. Then we come to strabismus. We've got different types of squints. We've got eyes turning outwards to eyes turning inwards. The whole, just to keep it in a nutshell, as far as squints go, would be, if it appears to be a squint, it's always a good idea to refer this patient to get a formal assessment done. Because with squints, you may have squints that are there all the time, squints that are there sometimes. These squints can be amblyogenic and cause a lazy eye as well. So with squints, what we do is we first assess them, we decide on what type of squint it is, and then we have exercises, we have glasses, and the last resort would be surgery to correct these squints in these children. Different types of squints have different timelines, and some squints we have to correct very early, other squints could take a bit longer. Infantile glaucoma, I'm not going to touch on very much, because in most of these cases, you will see an abnormality and refer these children. I know Rangika is going to talk about glaucoma a bit further, but the important thing in infantile glaucoma is, again, you've got to pick this up really early. It's not as common as adult onset glaucoma, but again, it's potentially blinding and at a much faster rate and a much earlier time than adult onset glaucoma. In adult onset glaucoma, generally the treatment would be drops and laser, surgery becoming less resorted to modality of treatment. But in infantile glaucoma, drops and laser are not very effective, so surgical management is generally the first line, eventually in most cases pretty soon. Now, if you see a child with a white pupil, that's something that requires urgent referral. It could be possibly a cataract. It could be due to various types of inflammation. Now, if it's a childhood cataract, is not something that lots of people are aware of. Lots of people think cataracts equals a 65-year-old, 75-year-old lady or gentleman who develops cataracts, but children can be born with cataracts. It could be in both eyes. It could be severely amblyogenic. So if you see a child with a white reflex, urgent referral, because unlike in adults, if we don't attend to this early and get the lens in its place and remove this block to vision getting into the eye, there could be deep-set amblyopia that could develop, right? Also, another problem with a white pupil reflex could be the chance of it being a retinoblastoma. So you don't want to miss this. Like I said, the malignant tumor of the retina, you don't want to miss this. If you see a white pupil, I would say the safest thing is, without assessing, explain to the parents the importance of getting to an eye doctor as soon as possible in both cases, right? Retinopathy of prematurity, you could have parents coming to you for advice, but most of these kids would be under the pediatrician's care, and they need regular follow-up and this needs to be managed with either laser or with intravitreal injections of anti-VEGF agents. Again, the retinopathy of prematurity, on one hand, is becoming a bit less prevalent now because we're managing our oxygen in our NICUs better. At the same time, it is still there because we are delivering younger babies as we go, because they can survive. Younger babies can survive because of technology, but the problem is that they end up with eye problems if we don't screen and treat them. The next common thing that we do see, maybe 5 to 10% of all infants, is a blocked naso-lacrimal duct. So if you have a block in the tear duct that drains all our excess tears from our eyes into our nose, which we all have, and that's why when we cry, every time we cry, we need a hanky, because all the extra tears is what drains through our nose. If you've got a blocked tear duct, you will have a child with discharge and who would be tearing excessively. But the clue here is that the eye would be not red. The eyelids could be red, but the eye itself, the conjunctiva, won't be red because there's no infection, just a collection of undrained pus, discharge, and tears. So here, a massage of the nasal, starting from the nasal end of the eye all the way down the line between the nose and the face. You do that a few times. It's called hydrostatic massage. You flush and you push the tears in the duct down, and you open the block just like you would push water into a pipe and try to open a blocked pipe. And this works in about 95% of cases of children by the time they are an year and a half. And if not, we can actually put them under anesthesia and do something we call a probing, where we send a small a metal probe into the duct and open that block mechanically. Ocular allergies are a very common thing, often associated with general allergies as well, like asthma and allergic rhinitis. Itching is the main complaint. There will be a prolonged history. There will be ups and downs depending on seasonal factors as well. So what I would always say is, if it's not bothering them much and it's not a regular occurrence, is I'll give them conservative management approaches like washing the eye regularly, eyes fermenting without itching. If it's more regular and it is bothering them, then anti-allergy drops. And rarely do we need anything oral or systemic unless it's a very, very severe resistant allergy. Ptosis, again, can cause deprivation and amblyopia, because when the eyelid blocks the pupil, then not enough vision is getting in. But in the majority of cases, your ptosis will be partial, which allows enough light and vision to get into the eyes so that we can observe and manage conservatively, and it ends up being a more cosmetic thing rather than an embryogenic problem. Now, as far as injuries go in children, they are of course prone to it because they're running around, they're falling, they're not too sensible when they're too young. But the important thing here is there could be blunt or sharp traumas, and sometimes what happens when a child comes shouting and crying with the eye closed, we are really not able to differentiate, and sometimes the history is not very clear as well. So if there is an injury in a child, best always not to try to force open the eyelids, because by some chance, if there is actually a sharp trauma and there's an open globe, like you see with this corneal laceration, by trying to force open the eyelids, you're actually going to put extra pressure on this open globe and possibly even force out contents. So if there's a child not opening the eyes, you give them a bit of time to let them spontaneously, gradually open their eyes. If they don't, it's always better to sort of just pat the eye, put a sterile bandage over the eye, and then go get it checked at an eye department closest to you. And in sharp injuries like you see the injury to the lid or the cornea, suturing will be required. If it is a corneal injury, there is going to be a scar if this injury is sutured, and that will lead to significant degrees of amblyopia, which we'll have to deal with later. Blunt injuries, also very common. Again, you could have subluxated lenses, you'll have other problems, fractures around the orbital wall, and those also will have to be treated. Orbital cellulitis, of course, if you see a child like this, the chances I'm hoping that you'd be urgently referring this child to the closest eye department. It is an emergency and they need intravenous antibiotics as soon as possible. So just to end up there, I know it was a big rush through. I didn't want to put too much information there, just highlight the important areas where we could help manage these children. So the take-home message would be, number one, because of the possibility of amblyopia in all children, a regular exam to pick these conditions up is always the best way to go, because children are not old enough sometimes to tell us that there's something wrong with the eyes. If there's anything that looks different physically, generally the case is that you will be referring these children. And also just to reiterate the importance of outdoor time, because I feel with all these conditions, my real worry in the future is myopia. I mean, such a simple thing. And we know a lot of research coming out now that if we do spend enough time, especially, for example, if both parents are myopic, we need to have those kids spending even more outdoor time. So a lot of people thought that it was a lot of the indoor time and the devices. Now it's looking like less of that, but more the fact that when you're indoors and on your books and devices, you're not getting enough sunlight. So now what I would say is, even the online classes, if it's 6 hours a day, if you can spend as much of those 6 hours outdoors in the garden or on a balcony or where there's a bit of sunlight and following those online classes is much better than doing it in a dark, quiet room, right? So outdoors, sunlight as much as possible. Sports activities, physically good for you as well. So these are the few things that I'd like to highlight. So thank you very much. And any further questions, you could call me or send me a message straight on this. And do we get a chance to, is there anyone who can ask questions? Oh, yes, no questions. Okay.
Thank you very much, Dr. Amila De Alwis, for a concise yet very comprehensive presentation. I hope as GPs we would agree that this is what almost more or less what we see every day in practices. So this is, since we are a bit pressed for time, there will be a quick round of Q&A session if anyone has any questions for Dr. Alwis. Yes, there's one anonymous question being asked from the crowd.
Anonymous questions are always a good one.
Does using wrong lenses damage eyes?
Well, using the wrong, what I'm assuming is using the wrong powered lenses.
Exactly, yes.
Well, it won't damage the eyes as such, but because it will not give you the clear vision that you need to have for the vision to develop, there will be a delay in treating amblyopia, and then that could potentially, yes, result in amblyopia. But, a lot of kids would not be comfortable, and anyway, kids are not going to like glasses, and they're going to find 100 excuses to not wear the glasses, a lot of kids, especially if they're very small errors. And if they're generally not the right number, they would come out. But yes, having the wrong powered lenses can not damage the eyes, but can prolong the recovery from amblyopia.
Thank you very much, Dr. Alwis. There's one question from the crowd. Yes, sir.
Hi, can I ask, now we as GPs, we see a lot of our patients who bring their kids along to us who are all the time on their devices yes, playing games, and the mothers complain saying throughout the day this is it, they know nothing of the environment or the outside. Yeah. Isn't that going to have an impact in their eyesight sometime?
100%. So one thing about screens is that, you hear whenever I tell parents this, their thing is, I can't feed my child unless they're looking at the screen. Now, looking at myself, I'm a few kilos overweight, and I had no screens when I was, so I don't think there's any reason at all. If a child's hungry enough, they'll eat. So that's the first thing. I don't think there's a reason why you need to have a screen to distract a child. The next thing is, like I said, it's number one, I think staring at a screen and playing games, it's a problem in so many ways. Number one, you're not getting enough sunlight because most of this will be done indoors. Number two, you're not really interacting with other people because they're just stuck onto this. So you have lots of skills that are going to get delayed. And physically, so generally the recommendation is, as far as screens go, now the question was asked is, up to the age of 2 years, there should be not a single minute of screens given to a child. Because they found that when you give a child a screen, they're quite happy just to stare at that because that's quite addictive. And then walking to crawling to interacting, social, physical, all that gets delayed, right? So even in an older child, the screen, I'm not saying screens are all bad. Now, we know with online screens now that it's so productive. If not for screens, how would we have managed this last year, at least in the Western province? But the problem is that we've got to know how best to use these screens. There's lots of information that we didn't have when we were children, available at our fingertips because of the screens. But then, playing a game doesn't help us in any way. So I would suggest, keeping screen time down so you interact more, you develop more, and definitely not screens staring at, I mean, if parents ask me, you know, my child's coding or doing research or projects on a screen, it's a different story. But still, you'll want to limit it and do it outdoors if possible.
Thank you very much, Dr. Alwis. Please remain in this podium for a minute. Thanks for your contribution. And there is a little token of appreciation from the College of General Practitioners. I would ask Dr. Dinishani Hettiarachi to present Dr. Amila De Alwis the token of appreciation. Thank you, sir.